Um, so it's my pleasure to introduce Dr. Tayar to you. He is board certified in internal medicine and rheumatology. He is an associate professor in the section of rheumatology and clinical immunology at the MD Anderson Cancer Center, Department of General Internal Medicine. He is also the Rheumatology Fellowship Site Program Director at MD Anderson, the Clinical Medical Director of the ACB Internal Medicine Center, and the Observership Program at the Department of General Internal Medicine. Most of his time is dedicated for patient care, and he has an interest in education and muscular ultrasound. So I'd like to welcome Dr. Tayar.
All right, good afternoon. Thank you for having me. And today I learned a lot about PBC just by listening to the talk from Miller. And what we do in rheumatology is a little bit different than what you do in a liver clinic or in your gastroenterologist for PBC. And the angle we see PBC in rheumatology clinic in two different places. One, it is, as you all say, is presumed an autoimmune disease. And that's what we treat over and over again, autoimmune disease, except when it's PBC, we refer them to the liver specialist. So that's one part of our practice in rheumatology, is looking at autoimmune diseases and overlap with PBC or not. And the other part is the bone health. Us and endocrinology, actually, we deal with bone health all the time for the general population and more specifically for PBC. And that's going to be the focus of this talk, is bone health, osteopenia, osteoporosis, and the PBC. So you already heard about PBC and its common presentations. This is a review from the most common presentation, the fatigue, and going down the list. You heard over and over the past day or two. And again, today is one of the common presentations or complications, if you will, of PBC is osteopenia, osteoporosis, or weakening bones. The others, as we said, other coexisting autoimmune disease, that's what we do. Perhaps the most common would be in our clinic is Sjogren's syndrome, we call it. This is a dry eyes, dry mouth. Dr. Miller, dry eyes and dry mouth that you talked about. We call them Zika symptoms. That will be part of, that's very sensitive, part of what we do. But again, we're going to focus today on the bone health for patients with PBC. So depending what you read, the risks of having osteopenia or osteoporosis when you have a primary biliary cholangitis is somewhere from 20 to 44, I've read up to 50, up to half the population would have at one point bone loss. So why is that? The risk of having a bone loss or an osteoporosis will increase, as it says here, with the severity of your disease, how long you had the disease, but also, as you know, because PBC is also more common in women, and osteoporosis is more common in women, and especially postmenopausal women. That's another reason why we see it more often with PBC patients. Other risk factors, if you have a PBC, is if you have the liver fibrosis or the cirrhosis by itself, another reason why you might lose bone. Hypogonadism or other complication of PBC or presentation of PBC also puts you at risk for bone loss. Now, as we said, the prevalence of the osteoporosis or osteopenia will increase with the severity and the duration of your disease. In general, the PBC population have twofold increase compared to the general population. That's not too high to get osteoporosis or osteopenia. And the good news is, over the past decade or so, the prevalence of this osteoporosis tends to be decreasing. There's some evidence that it's getting less prevalence of osteoporosis for likely the good treatment of PBC and the more control of the liver disease itself, and perhaps the awareness of osteoporosis and the early screening and prevention too. So what do we do to diagnose osteoporosis, osteopenia? As I'm sure many of you had that test done. It's what we call a DEXA scan or bone density test. Not to be confused with the bone scan that cancer patients get to look for bone cancers. It's a DEXA scan or bone density test. And it is usually recommended to be done at the diagnosis of the PBC, at the diagnosis. So once you get diagnosed with primary biliary cirrhosis, usually your doctor should order a DEXA scan to establish baseline or to see if you already have some bone loss. And depending what society you follow, the European societies, they say every year you repeat one, the American maybe every 2 to 3 years. Nonetheless, it needs to be followed and repeated over a few years. So why PBC causes osteoporosis? The mechanism actually is not completely clear, or it's not clear at all. But there are some theories out there. One of them is it toxic metabolites from the bilirubin itself that's suppressing the osteoblast, which is the cell that is forming your bones. And we're going to do a little bit more on pathophysiology of osteoporosis in the next few slides. So suppressing bone formation could be. There are the theory from the before also that perhaps malnutrition and vitamin deficiencies that PBC gets, but that's not really been validated. In PBC, that's the vitamin D deficiency is the sole reason why you get osteoporosis. So who else gets, I mean, as we said, at diagnosis, you get the DEXA scan. When also, if you're getting ready for a liver transplant, it's a time, also good time to get a DEXA scan. Anybody who's going on steroids or glucocorticoids, as we said, it could be a second level of treatment for PBC when you fail other treatment. That's definitely an indication to get a DEXA scan, because glucocorticoid or steroid increase your risk of getting osteoporosis by several folds here now. Now, another good news here is, I mean, if you go for a liver transplant, if you have end-stage disease, after a liver transplant, the osteoporosis tends to improve fast. After 6 months to a year, we'll see significant improvement in the bone health after the transplant. So now the osteoporosis. Now, what is osteoporosis? Osteoporosis is, if you want, thinning of your bone or weakening of your bone. And this is a microscopic view of a normal, healthy bone compared to osteoporotic bone. So this picture is to just show you, it's more than thinning of the shell of the bone, what we call a cortex, which happens with osteoporosis, but it's also what we call a trabecular bone, with the mesh inside your bones. They get thinner too in osteoporosis, and eventually when you have the microarchitecture like this thinning, you put you at risk of fracture under pressure. So it is a cortical bone, the thick eggshell plus what's in it, both get thinner with osteoporosis. Now, this is some basic science, if you want, how you get osteoporosis, but believe it or not, this is something I discuss with my patient actually, with osteoporosis, because that will relate to the treatment we're gonna cover later. I mean, why we chose a medication over the other is important. So what happened in osteoporosis, your bone is a live organ. And there are cells that always resorb or clear the old bone, and the other, we call them osteoclast, and other cells that always come behind them and build, we call them osteoblast. And there should be a healthy balance between two, where you don't lose bone and you stay in a healthy situation. So as this, and here you see the osteoclasts come and resorb old bones, we call them bone resorption. And the osteoblast is the cells that are responsible to filling those holes created by osteoclast. And obviously, any imbalance between either you're building slower or you're resorbing faster, you end up with a negative balance that we call osteopenia or osteoporosis. So it looks more like this. So the cycle goes over 3 months, where first you go osteoclast, resorbing the bone, and then after you have enough resorption, you have stimulation or activation of osteoblast to come in the holes and start building some bone and causing some calcification and bone formation. And this is a healthy, normal cycle. Now, depending on what treatment you get or what disease you have, you might have acceleration of resorption, and while, again, the formation is not that fast to keep up, and you'll end up with holes in your bone like we saw in the first pictures. So what are the risk factors here? This is for the general population, and the primary biliary cholangitis patients are no different. And these are the general risk factors for osteoporosis. The older you get, the higher the risk, and this is well established. The older age, perhaps the most important risk factor for osteoporosis. Then we have the female sex. Women get it more than men. Early menopause, because estrogen protects you against the osteoporosis. So certain women, for one reason or another, will have early menopause. in their 40s or 30s due to surgery, due to other complications, they are at higher risk of developing early osteoporosis too. Family history is also a big risk factor. So if you have a strong family history, we call it, with the parents or sibling with the bone fractures because of osteoporosis, that puts you at high risk population too. Underweight, and there used to be this magic number, if you're less than 127 pounds, that's a risk factor for osteoporosis. Smoking is a big risk factor, and that's one of the intervention we do for smokers. I mean, they have to stop smoking, or this will affect your further deterioration of osteopenia, osteoporosis. Alcohol in excess, and the definition here could vary depending who you ask, but I think here they say more than 2 drinks per day for women, and more than 3 for men could be excessive alcohol in consumption and puts you at risk for bone loss too. Drugs, the biggest one here would be corticosteroid or prednisone or prednisolone or dexamethasone. All this family puts you at high risk for osteoporosis. There are others we use for breast cancer. We call them aromatase inhibitors. That's also putting our patient population, especially at MD Anderson, at risk for osteoporosis. And many other drugs, we're not going to go all over them. And there are certain disorders, exactly like PBC, by itself puts you at risk for osteoporosis, and there are others like hyperthyroidism, hyperparathyroidism, and other diseases. And there are some genetic diseases. So these are the general risk factors, not much different between PBC and others, except there are little, as we said, maybe 2-fold higher chance of getting osteoporosis. So why this is important? So some PBC, we say, we have a liver disease, we worry about that, we worry about fibrosis, cirrhosis, we have so many things to worry about. I'll deal with my bone later when I get older. So the bottom line here for osteoporosis is the risk of fracture. So why we treat, why we prevent, why we follow these patients, because they are at high risk of fractures, and these fractures could have some nasty complications. So there's some statistics for you here. Sorry, I keep pushing the wrong button. So 1 out of 2 women and 1 out of 4 men above 50 years old will have an osteoporosis-related fracture during their lifetime. This is not low numbers. And by 2020, it's estimated that 1 in 2 Americans above the age of 50 also will have a certain fracture related to osteoporosis. This is common enough to be a public health issue. And there are some serious, as we said, consequences to fractures. Is it from pain, disability, and even mortality, especially for hip fractures and elderly population. And as a matter of fact, it might increase your risk of mortality per year by 10 to 20% for certain age women for the hip fractures. And there are up to 20% of patients with hip fracture will end up in nursing homes. And only 40% of elderly women postmenopausal with hip fracture will recover complete, or they go to their baseline function after it. So it's an important issue when you look at those numbers to treat and to prevent. The vertebral fracture is mostly about pain and disability, more so than mortality, but it could be very serious pain, and then some end up on chronic pain medication after vertebral fractures. And there are also other osteoporotic fractures. It is not limited to the spine or the hips. It could be in basically any bone in your body from minor injuries. The wrist could be another common one we see. And it's mostly about the functionalities. That's where wrist fracture may be less of a serious fracture than the others. The challenges remain significant for osteoporosis because up till now it is still undertreated and underdiagnosed disease compared to the prevalence of the problem. So it's often asymptomatic. So osteoporosis by itself will not give you pain. That's not your cause of back pain unless you break something. So usually it's